Welcome, everyone, as we get settled. And thank you for being here on this important election day. I can't imagine a more germane topic than maternal mental health. I'm Becky Messing-Hagler. I'm CEO of Noe Strategic Advisors, and I've also served for the last year as a fellow at the Kennedy Forum. We'll talk a little bit about the 90-90-90, if you're not familiar with the Patrick Kennedy and the Kennedy Forum put out last year at Alignment for Progress during the course of the conversation. But before I do that, I want to very much introduce my three esteemed panelists here. To my immediate right is Jamie Zalway-Balsito. Jamie founded the Maternal Mental Health Leadership Alliance in 2019 to keep a focus on national policy around maternal mental health, and she's been a key advocate in passing federal legislation to address the nation's maternal mental health crisis. So Jamie really is a policy expert, and we're excited for her perspectives. Over dinner last night, we had some good conversation of all the challenges, including the data and the measurement required to deliver on the promise that we have for women and families. But I want to just also comment that Jamie previously represented the 4th Essex District in the Massachusetts House of Representatives. So she does also hold the lens of an elected official. That part of our conversation is how do we convince government, right, that we need the funds. We know this is an important topic. I don't think there's any debate in that, but how do we execute and deliver? To Jamie's right is Dr. Nancy Byatt. She is a perinatal psychiatrist and physician scientist focused on improving systems of care to promote mental health of parents and children. Nancy is a professor with tenure at the UMass Chan Medical School. Her expertise includes psychiatry, obstetrics and gynecology, population and quantitative health. So we're going to really look to Nancy on how do we properly structure these studies and get the longitudinal data we need for success. And the most important thing, well, Nancy's done many important things, but the thing we're going to talk about today is the program she essentially, her leadership founded, which is MCPAP, the Massachusetts Child Psychiatry Access Program, MCPAP for moms, but that model has now served as the foundation for the best-in-class standard of care, which has been scaled across this country in more than 30 states. So we look forward to hearing more about MCPAP. And then finally, my colleague and dear friend Malakay Amini. Malakay is the CEO and founder of Trait, a technology company in behavioral health, increasing access and quality mental and behavioral health services. The Trait platform is streamlining workflows, objectively measuring outcomes, and its multifactorial approach using both the medical drivers and the non-medical or social determinants is really leading the way in how we define evidence-based care. So with introductions out of the way, I'm so grateful to welcome you three fabulous women to this stage, and we'll dive right in. We have to do some sobering stats because that's my job, I think, as a moderator, but we know that maternal mental health conditions are the most common complications of pregnancy and childbirth. Many in this room, I'm sure, have experienced them themselves personally, impacting 1 in 5 pregnant and postpartum parents. They're the leading underlying cause of maternal death. It's sobering, the reality that women are struggling, women and families. We're using the term women in the broader sense of parents. And research continues to show that perinatal and postpartum mental health issues have long-term adverse effects on babies, siblings, and spouses. However, the exciting news is that with early identification and intervention, we can change that trajectory. So what we're going to talk about today are some of those innovative approaches, not only to how do we solve the challenges in maternal and mental health, but how do we measure and quantify how these interventions are working such that we can get the funding to scale them. And then finally, as I mentioned, the 90-90-90 is a nice construct we can use. The 90-90-90 was established, if anyone was in Boston for the Alignment for Progress in 2023, with the help of McKinsey Health Institute. 90% of individuals, it's a true moonshot. I'm from Silicon Valley, and so we like to put things out there that are bold. But we love it because it's 90% of individuals screened for mental and behavioral health in this country. Can you imagine that in 10 years? We're going to do this, right? We're getting there in screening. The middle 90 is where we're going to spend a lot of time in this panel. 90% receive evidence-based treatment. So what do we mean? How do we know what models are evolving? And then third, 90% of individuals are able to live in longitudinal or in long-term recovery, managing their symptoms. So following and tracking and knowing where people are longitudinally is, I think, a big, that to me is the true moonshot in mental and behavioral health. So with that, I'm gonna first ask Dr. Byatt. Your vision and thought leadership laying the groundwork for the Perinatal Psychiatry Access Program in Massachusetts, MCPAP, created a model which has now been replicated, as I mentioned earlier. So can you talk about the core components of how you developed that model and how that model has then been able to scale across the country?
Yes, I'm happy to. So my passion for this work is deeply rooted in my personal and professional experiences. And so I grew up acutely aware of the importance of maternal mental health because I saw my mom struggling with the result of her mother's perinatal mental illness. My grandmother when my mom was born, was very depressed, likely due to bipolar disorder. Long story short, they went to their family physician. They told them that they should put an ad in the paper and found someone to take my mom. So they did that. And my mom was sent to go live with a family she'd never met for 6 months during her first year of life at the recommendation of the family physician. And they never had any contact with her biological family during that time. When my mom went back to her biological family after 6 months, I think my grandmother never recovered. From what I could tell, my grandmother was profoundly depressed, alternating with what we see with bipolar disorder throughout my mom's upbringing. So I saw my mom struggling with this. This impacted me, my mental health, and also my children's mental health. And you fast forward, I became a perinatal psychiatrist, no surprise when you think about my origin story. And I was running a co-located clinic as a psychiatrist, seeing pregnant and postpartum individuals. And I would see all these individuals present to me who would come to the clinic, who it took months for them to get in to see me. What I was doing was not that hard, meaning I was providing pharmacotherapy. And they would often be telling me these stories about how they never knew they were depressed. 2 years later, it wasn't until they came out of it that they realized it. People would tell me the baby felt like an alien. They weren't there for that baby's first year of life. And it really struck me that it had this profound impact on them and their baby. And they saw many healthcare professionals who never asked them about depression, never talked to them. You talk about the 90-90-90, it was like 0-0-0. And there was just nothing happening. And so it was a missed opportunity to talk about this. The individuals, of course, didn't know, and it had an impact on their kids. On their babies. And I was, and as a psychiatrist, I thought, well, there's this relationship where we have healthcare professionals seeing pregnant and postpartum individuals. They don't know what to do. And we did focus groups, and this is what we heard. The perinatal professionals told us, we don't know what to do. We want to address this. We have no idea how. And the individuals' lived experience also told us they don't know what to do. We want to talk to them, but even if we do, they don't know how. Like an example is, in one focus group, somebody said, they screened positive for depression, and somebody said, well, you have a happy, healthy baby. What else do you want? That's clearly unacceptable. So that led us to think about, well, we knew there was a child model for kids where pediatric clinicians can call and speak with a psychiatrist to help build their capacity to address child mental health challenges. So we thought, well, can we do the same for perinatal care professionals, primarily obstetric clinicians? And we did that. So that is the MCPAP for Moms, the Massachusetts Child Psychiatry Access Program for Moms. We developed that in 2014. And at the time, it's expanded since, but it has three core components. Training, so we go and we train OBs. How do you talk about this? How do you be trauma-informed? How do you destigmatize? How do you screen and then address and respond to a positive screen in a way that's helpful? And we also provide consultation in two ways. We can, if a patient screens positive for depression, the OB can call us. We'll basically hold their hand and help them talk to the person, manage them, prescribe if needed. And if it's more complicated, like bipolar disorder, we can see them for one-time consult. And we can typically get people in for that within 2 weeks. In the state of Massachusetts, of public health insurance, it takes at least probably 6 months to get in to see a psychiatrist. We can see people for 2 weeks for a consult, and then we help the OB prescribe. And then the third thing that we do is we provide resource and referrals to help navigate what we all know, and why we're here today, is a very, very complicated mental health system. And as we heard, because the model is not particularly expensive, so in the state of Massachusetts, if someone has untreated depression, it's just about $350 million a year for untreated mood and anxiety disorders in the state of Massachusetts. And our program costs just over $14 per woman per year, or just over $1 a month. So it's a lot less expensive. And because of that, and due to advocates like Jamie, which will be a great segue to Jamie, it then led to federal legislation for other programs like it. We now have 30 of these programs across the country. That is fantastic. We're very proud of that. There's challenges with that, which we'll come back to later. And people often ask, well, how did this get all across the country? And I'll say that it is a light within our wounds, including Jamie and her advocacy, and using her lived experience to get this funded throughout the country. And that is why we've seen this movement. It's due to that. And so it's a good segue to the
I don't even have to ask the question. I think over to you, Jamie. How are we able to scale this from a federal policy and advocacy lens and your experience doing that?
Sure. Thank you. I'm at a technology conference and I can't turn on a microphone. Lay out the question one more time. I have a lot of thoughts racing around here.
So from a policy standpoint, how were you able, through advocacy, able to scale the beginnings of this model that Nancy just described?
Sure. So here's the deal. There are just very simple, accessible ways to go about treatment. And I will share, I come to this space by way of my own lived experience. I think a lot of us in the mental health space always have a personal story. Why are you here? I don't think my 14-year-old self thought I would be a maternal mental health policy or subject matter expert, but by way of my own lived experience. And lack of access. Now, I am from the Boston area that prides itself on access for medicine and will repair the heart of the King of Saudi Arabia. Adele got her vocal cords fixed there, okay? The Red Sox all received their treatment. The Red Sox are very important to me. They'll come up several times today. And when I experienced something that I, didn't even know existed, why was I experiencing OCD, compulsive thoughts of suicide ideation during and post-pregnancy? Not one provider ever spoke about it. And it's the #1 complication of all pregnancy. And it's the #1 cause, comorbid with substance use, that is the cause of maternal mortality in this country. I'll also transition into this. I'm white presenting. I speak English. I speak Bostonian. I am married, private insurance, a wanted pregnancy. I have a home, and I could not find any support. That is egregious. That is a lack of seeing very low-hanging fruit to educate women while they're pregnant. This also, no, don't worry, not just the diabetes and that horrible drink that you have to have, and you know, how to feed the baby and the boob and the whole thing, right? But how is your mental health? You're not just a vessel, you're an actual whole human being. And how do we care for you going forward? The racial disparities aspect of this is also egregious. That was something to me that I said, if people that look like me, that speak English like me, and I can't find that support, what does that mean for everybody else? So we saw an evidence-based model that was far superior than, I am going to say this, it's in the rearview mirror, than the World Series that the Red Sox, when they finally beat the Yankees, okay? Why can't we replicate something that costs $14 a day that's going to save lives? Why can we not do that? So we took this battle for, say it again?
It's $14 a year.
$14 a year. See, I feel like it's Sally Struthers when she used to be like, for 50 cents a day, you can pay for this child to eat in Nicaragua. So I apologize. $14 a year. That is per woman. That is so low. It's negligible when we take a look at budgets, when we take a look at healthcare, and when we look. This is something that should be readily accessible and put into our community-based organizations. And this is a model that we took to Capitol Hill. It made sense, and I will say this, it was the first time that I've seen a women's health issue actually be bipartisan and looked at as something that we could work on. And so that is the beginning of a love story of Nancy and I working together and being here today.
I can't wait to continue that love story. You don't have to turn it off. It just does it for you. Just hang tight. Okay, so then over to Malachi, and we're going to come back to this love story in a second. But so we know the challenges. So evidence-based models, $14 a year, and women are suffering. Women and families are suffering. We have all the racial and equity, components of this. But how do we bring together solutions that can actually bridge that gap from a data and technology perspective? So my question to you, Malachi, is how do these technology solutions help close those gaps, and what kind of outcomes are we beginning to see when we invest at the Behavioral Health Technology Conference, technology?
Thank you so much for the question, and I'm so excited to be on this panel with all three of you. I'm humbled by my presence on this panel. But so as Nancy and Jamie also discussed, it seems like mental health generally pulls from the heart. Most of us who are in this industry are probably here for a personal reason. My journey, I've been in the healthcare and health tech space for 30 years, but my journey in this path started when my own son was diagnosed with a series of neurological and psychiatric, non-psychiatric comorbidities. And throughout that process, one of the things that I had identified was that the clinical care, the process of actually caring for patients, the way we measured their outcomes, the way we diagnosed them, was ineffective, insufficient. And so I found a trait on three principles. One was medical, non-medical drivers of behavioral health at symptom level, so really combining social determinants, adverse childhood experiences with the clinical symptom, manifestation of those conditions. The second one was the entire ecosystem around the patient. A single observation by a psychiatrist or by a psychologist is not sufficient, and that there are a number of other observers. There's the environment of the patient that highly impacts not only the risk of for a condition, but also in how they responded to treatment and how their outcomes improved. And then the third component was access to care. Number one, for exactly what Jamie, you were describing, which is our own limited level of access. And I was on the board of Baylor College of Medicine. I had a lot of access. In fact, I felt like I got the treatment that most people don't get, but that was literally that one time. And an ongoing basis, it was very hard to know how to get to a physician or a provider of any level that could, in fact, answer even a simple question. So that's how I started this company. But one of the things about access is that we are not structured as a country, as a healthcare system, we're not structured to collaborate. Our systems are institutional. They're not speaking to each other. So when you have a patient that has to see multiple providers across institutions, it's almost impossible to collaborate. So one of the components of technology that I think is very important is the ability to streamline those workflows, is to sit on top of those institutions, especially when it comes to access. It does mean that it needs to connect disparate systems that don't typically work together. And so it seems like all of us, at this on this panel have built our lives and work around what Nancy has founded, which is enabling the psychiatry access program. So we started in child and adolescent, which also was a Massachusetts, it's a MCPAP program, and then expanded that into maternal mental health, which has now become the fastest growing part of our business, actually, is growing across the country in maternal mental health programs, which are, again, modeled after what Nancy in Massachusetts founded and Jamie helped get funded. And so the thing about the technology now is that we are able, in fact, to connect these disparate systems. So the beauty of the program is that you, as a state, have to work together in order to deliver access. Through the OBGYNs or through pediatrics. And so one of the things that's really important, and we fit well into that model because of our ecosystem model, is that we have, there is obviously a shortage of resources, but there's also disparity across, in resources. So there are areas in a state like Texas where the state is so large, you may have to travel 4 hours to get to the first resource for a 50-minute session. So the ability to go outside of that shortage area or the behavioral health deserts and be connected to another institution in Texas or in Massachusetts that can respond was a key factor. And that's one thing that I think really, so that enabling that workflow of being able to connect from one institution to another. If somebody needed help, if Boston doesn't have the support, someone in Framingham can respond to it, but those are too close, but in Salem can respond to it. But the ability to expand access through multiple institutions and really overcome the barrier of silos was one of the aspects of technology that I think had facilitated the programs and streamlined it in a way where there was a lot more administrative costs. And much of that funding could be really serving the patients and the patient needs or the primary care physician's needs. Another aspect of that is really the data itself and the analytics behind the data and the measurement. Right? So one of the very important aspects of this program, obviously, is engagement, is getting the OBGYNs or the pediatricians to know the program exists, to know they can contact the program and receive the kind of advice and education they need in order to provide the care they can within their own clinics and therefore deliver the right type of care at the right time wherever the patient is, which is in the clinic of the primary care. So measuring that is very important. That's a core part of the program. And we were able to measure that through a number of different granular levels of data that we were collecting. But I think one thing that we expanded, because we are, at the end of the day, we are a measurement-based care clinical platform, was to really expand that beyond what the engagement of the primary care physicians were, and to focus a lot more on clinical data, on measuring outcomes, on measuring whether the patient is receiving the right type of care, whether the program is, medicating, families or, moms at a certain level. Like being able to track what is really effective and what is the program delivering in terms of care, and how are the OBGYNs calling in for more complex problems, which means some of the simpler problems are getting resolved with that education within the primary care physician's office without the need to call anybody. And so those are the types of things that we were able to measure. And I think that is something that has expanded in many ways or enhanced the measure of quality for these programs. And I think that more and more we see a lot more of that demand across the country to be able to expand this. So Texas, for example, is now incorporating, and we're building a platform around this now to screen moms during pregnancy and postpartum on an ongoing basis. Therefore, enabling early intervention, even if the mom is asymptomatic, even they don't have symptoms of depression or anxiety or any other condition, but to screen them ahead of time has been something that I think we'll see more and more of that focus on patient health outcomes, screening, and tracking that information through the program.
Great, thanks, Malakeh. And I think the Texas use case, as she highlights, is a really interesting approach to a statewide successful implementation of maternal mental health, access, and then now the outcomes. So we're going to pivot a little bit now in terms of we've come a long way, but we have ways to go. And so I'm going to ask both Jamie and Dr. Byatt to talk about, from your point of view, what are those gaps that we need to close in terms of not just going and getting more funding, but how are we measuring and quantifying the impacts we're having for this entire population in our country? So Jamie, we'll start with you. Where would you like to go, and where is your organization going to get the data to continue to lobby for the support of these programs?
Thank you again for the conversation that probably we could do a nice 2 to 3 hour session on here. So wanted to just quickly touch upon the nonprofit I founded and what our vision and mission is. Now, we are solely based to improve the mental health of mothers and childbearing people in the United States, with a focus on national policy and health equity. And our vision, what we want to do, what we can see is so readily available to do, is provide universal and equitable education, prevention, screening, and treatment for mental health conditions during pregnancy and the year following pregnancy. I will also say this, I think it's more like 2 to 3 years following pregnancy, okay, as we look into this, because manifestations of the biophysical and chemical balance that affects mothers' units, it's another reason why we have to talk about spacing out family planning. There's a whole host of things that we don't have time to talk about: paid family leave, access to child care, parental leave, all the things. We are in a society that has made it so difficult. You cannot get out without having sometimes 2 to 3 jobs, one parent, and if you're lucky, you have 2 parents in that house, and you can spend an upwards of $60,000 a year for child care. There's a lot of broken things going on here. Housing, I'll have a session after this. We can talk about it, all the problems. But what I do want to say is this: it is screening. The pediatrician's office, right? I love it when you go to that 6-week appointment. How are you feeling? How am I feeling? Did you take a look down there? How do I feel? I feel terrible. Okay, like I had a cesarean section. I had staples keeping my stomach together. You know, like I feel terrible. You're asking me what am I doing for birth control? She's in the carriage over here. Like, you know, we're not talking about the fact that the first person you're going to see is the pediatrician on like day 1 after you get home. So if the pediatrician's checking in with you and saying the baby's fine, right? Like literally the baby's like an elastic rubber band, like a rubber band. The baby's fine. You're feeding it, it's great, everything's fine. How are you doing? Day 3, day 5, day 10, all of these things. We need to have screening implemented, and we need to have the partnership. I'm going to give a shout out to a colleague of mine here, Dr. Jessica Galton, that has a family well, that it is the intermediary between the OBGYN's office and the mom to check in. Nancy's program, which is so incredibly important. I mean, we're funding $5 million annually out of a federal budget to get to 30 states, and then states are taking their own opportunity to do this and fund it within their own state budgets. That's scraps. That's scraps, okay? Don't insult me with $5 million, but at least we got our foot in the door, because then it led to the Maternal Deaths Act that showed that substance use and mental health are the #1 cause of maternal mortality. And when we take a look and we break that down into the racial equity piece, then there are physical manifestations, cardiac issues with women of color, in talking about weathering and the impact of racial disparities and all sorts of things. There's so much to be done here. The federal government needs to lean in, and we need private-public partnerships, and that's what we're here to do, because there's a unique opportunity for technology to fill this gap. There's a unique opportunity for technology to work with the governments, and there's a unique opportunity for us to come here and figure out if we're not going to wait on the government that goes at a snail's pace to be there, how do we use the power in this room to address the #1 complication of all pregnancy and the #1 cause of maternal mortality?
Well, with that, that's over to you, Nancy. But the question is, how do we take this data and then go out and fund these programs at scale? We've foot in the door, which is a start.
Public-private partnership.
And I'll come back to the public-private partnerships for sure. But Dr. Byatt, what do we need to do to get the comprehensive data? No one's arguing that this is a problem, but how do we longitudinally track now the success of these programs?
Yeah, it's an excellent question, and I would say there's sort of 3 things I'll focus on. One is we need to know our denominator. We always talk about population health. We can't do population health if we don't actually know the number of who we're trying to treat. So there's that piece around really thinking about population health. The second piece is thinking about workflow integration and really having the whole care pathway. And then the third piece, I'll touch on each of these briefly, the third piece is pulling that data together so we can have our friends like Jamie and others actually know how these programs are doing across the country, so that can then inform policies. So starting with the first piece, I think Malachi spoke very, very well to the importance of these access programs across the country, both child and perinatal. There's 30 perinatal, there's over 50 child programs. So this model is everywhere, and there is major challenges with evaluation. I serve as a consultant and am in a lot of meetings across the country with child and perinatal programs, and I am amazed at how many challenges there are with evaluation, data collection, and then using that data to actually improve their programming. People are collecting all sorts of data. One of the challenges we see, it sounds easy. We'll collect data, we'll use that data to improve our programming. For example, who are we not serving? Is there inequities within the populations it's serving? If we're not engaging that population, why not? That sounds simple. It's actually incredibly complicated, and that is often not happening. And part of that is we need data systems that can facilitate having, like quality improvement cycles, like plan, do, study, act. Who are we engaging? Who are we not engaging? How can we improve that? And how can the data help us to do that? So that's one really important piece when we think about any sort of quality improvement, but particularly for access programs, which are statewide programs. One simple example is access programs for perinatal programs, they engage with obstetric practices, right? Many of them don't necessarily know how many they have. You don't know who you're engaging if you don't know the denominator of how many you're meant to engage. So having data systems that facilitate that kind of evaluation and engagement opportunities. So the second piece is when we think about workflow integration. So when we think about the care pathway, detection, ideally should start with prevention. Prevention, then there's assessment, treatment follow-up, monitoring until illness remission, right? Jamie talked about when you go there, the baby's like in a lot, like when you ask your friends or your colleagues, like, how are you doing? You're not like, oh, my kidney function's fantastic, and my BUN and creatinine are amazing. Like, you don't talk like that. We talk about how we're doing. We talk about our mental health. We talk about that. And I think that thinking about workflows where that relationship between, the baby and the parent and the professional they're working with actually is leveraged in a positive way that's trauma responsive, and creating workflows, and technology can help us with that. So for example, this would be my vision. There's a prevention app that you start doing, and it extends the human. It's not gonna replace the human, but it could extend them. They review that in a visit. And then there's a screening done, which could be done through technology. And then there's a dashboard that helps the provider figure out what to do after that screen. And then there's measurement-based care, so that you're following symptoms, and if people aren't getting better, you adjust treatment in response. And technology can help with these things. And then I would say the third thing is really important to have data collection across programs, because Jamie and MMHLA and the Maternal Health Leadership Alliance will often contact me and say, hey, what do we have for the data across the programs? How much are they being used? How many patients are we serving? We honestly have no idea, and that's not good enough. We really need to understand how we're serving and have ideally a data coordination center, and also ways that we can do program evaluation within and across states and use that data to be able to inform how do we best implement these programs. They're being implemented in all different ways. We don't actually have an evidence for what's the best way to do it. How do we best engage people? How are we improving outcomes? And then also that we can feed that data back to policymakers to be able to make evidence-based decisions around funding.
I want to piggyback on exactly what Nancy just said, and I think folks that are in this room that are utilizing technology, like Malika is going to speak about, is that you have access to data that we need. And if you're filling in this intermediary space that the CDC doesn't have or HHS doesn't have, and you're showing that, for instance, we're seeing that handheld BHT is screening women of color at a much higher rate than if they're in the office, okay? This is what we need to see, is being able to access data into our tribal communities, into our Latinx communities, wherever your community is, and that's what's going to drive. Policy doesn't get formulated around this without the data points, and that's what I'm constantly looking to go to legislators to say, did you know that this is what's happening in your state? And you've been able to work on that, Malika. Thank you.
Yeah, just quickly, just chiming in, one of the things you brought up, Nancy, about the continuum of care. it really does expand, right? So when you look at, for example, maternal mental health, if the mom is receiving care because of some mental health challenges, being able to share that information from OBGYN to pediatrician the first day you go there, it actually does, especially knowing the risk that it poses on the infant overall, long-term impact on mental health and and even developmental health. I think that's one of the areas where I think we've been able to expand our platform, which is navigating between OBGYN and pediatrics through technology in a way that's seamless to the pediatrician or to the OBGYN, but to enabling that kind of connectivity is something that I think fits well into the continuum of care, just beyond even the maternal mental health component of OBGYNs, but really all the way into the child's development.
Yeah, much more to say on that, and I think where the comment on public-private partnerships matter is we do actually have to bring this data together to tell the whole story, and so it's a great theme that we'll come back to. I do want to switch gears just for a minute, because it is election day. We do want to talk a little bit about how this advocacy is playing out, and we will find out over the course of hopefully the next day or so. But according to Kaiser Family Foundation, reproductive health has become the critical issue for women under the age of 30. It ranks now above inflation, and 40% of women under 30 say reproductive health is their top voting issue in today's election. So regardless of political views, Malachi, what do you believe will be the impact of our decisions today on maternal mental health, and how can we continue to work to make sure that families that are impacted have the support services they need?
So I think, as you said, the data has shown that, especially with states that have limited reproductive rights, there is a significant increase in the level of anxiety and depression within families, and also a component of fear of not being able to access care in life-threatening circumstances. One of the kind of immediate thoughts is in those states, and I think there are 10 states on the ballot today for that. So for states that do have that kind of limited access, it is important for those states to invest further in mental health infrastructure for families, altogether. And this actually expands beyond the pregnancy. It is for any woman of childbearing age, so starts in teen years and young adults, and it impacts the entire family. So we also need to think about, when you talk about the first 90% of the moonshot, it really is to think about starting, universal screening as teenagers for young girls, and continue that on to detect the risk of those types of anxiety and depression symptoms and address them. You can start the clock sooner, not before pregnancy, and to really start to do the universal screening early.
Yeah, absolutely, everything Malachi said, and I think it's quite simple in that restricting, so I don't think this is about, people can have their views, right? This is about not interfering with evidence-based medicine, and access to abortion is an evidence-based medical practice that we know improves outcomes. It's very clear. And when access to abortion is restricted, it makes pregnancy unsafe for everybody. Because, so in Idaho, they have restricted laws around abortion. All the high-risk OBs have left. They already had maternity care deserts. We have so many maternity care deserts in this country, and when we restrict abortion care, it's not safe for OBs to practice. They can be criminalized, and particularly high-risk OBs, maternal fetal medicine physicians. So they're leaving. They're leaving, and they're going to places where they can practice safely, or when they can practice evidence-based obstetric care. And so we make it unsafe for everybody, and we particularly make it unsafe for individuals that are already experiencing marginalization or oppression due to racism or other forms of oppression, because it's going to be hardest for those individuals to be able to access care due to the many, many barriers they experience. And so it's evidence-based care, and we need access to it, and if we don't, it's unsafe for everybody who is pregnant.
And I'll add to that. I'll use Georgia as a reference point. I have been, honored and privileged to serve as a elected public servant and work with a wonderful group called the National Foundation of Women Legislators. And when you're in these rooms, and people are independents and Green Party and Republicans and Democrats. You're there to collectively think about how do you make society better through policy. And 2 years ago, I was in this amazing space in Charleston, South Carolina. So it'll be South Carolina and Georgia. And these Republican, very conservative Republican women senators said point blank, we are not going to allow there to be a abortion restriction in our state. You know, I'm a mom of 5, but I only have 2 living children, right? Like these are, we cannot interfere with health care. And they all got voted out of office by more conservative Republicans. And in Georgia, we've seen 2 women now, 2 women because of the maternal mortality review committees, be specifically reported on that they lost their lives because of restrictive abortion care, because the doctors don't want to take care of you because they're afraid they're going to end up in jail. So they want you to be in a parking lot near death before you're able to be seen. I will say this right now for myself, I would not have my 2 children right now if it wasn't for abortion care. And that is the reality of it. I had a miscarriage at 3 months for a wanted pregnancy. It was not a completed miscarriage. I had placenta still in my womb a month later. I hemorrhaged out in front of my home, and I had to have abortion care after that. I would not be a mom. We are actually penalizing people. Those 2 moms wanted pregnancies, and they could not go get it. And now you have children who are motherless because of these policies that do not do anything but criminalize, demonize, and use religion, which should not be part of any policy in this country.
Yes, a lot there. So in our final, no, these are real issues. And we are going to the ballot today, as everyone knows, to sort them out, going to the polls. And so in the interim, we're going to talk about what makes us optimistic and what we're going to be working on, because we just have time for one last set of comments. So I guess I'll start with Malachi and come back this way. In terms of just how we were framing the 90-90-90, what gets you most excited as we look to that ultimate 90% screen, 90% receive evidence-based treatment, and then the third 90, which is the true, holy grail, is 90% of individuals in this country living in full recovery with their symptoms of mental and behavioral health. What gets you excited?
So I think what we see in maternal mental health is a reflection of actually just everything that we see in women's health in general, and the focus. I think one of the things that's really encouraging is the fact that there is, number one, that there are a number of real advocates that are decision makers, and we see sort of First Lady Dr. Jill Biden, advocate for this. It's just around women's health, and I think the mental health of women actually has a much more serious consequences of, if we don't address them, not just because of the fact that that woman is impacted, that mental health is impacted, but we know the impact of mental health on physical health. And then we also know that that kind of, that the mental health of a mom actually impacts the whole family. So it has some exponential growth. And I think that what's really encouraging is seeing something like the 90-90-90 moonshot, or seeing a lot of really great initiatives beginning, not just addressing postpartum care, but also just generally women's mental health, maternal mental health at a much broader level. And I think that's really important. That's very encouraging. And one of the things that I think is still needed is for us to recognize that this is no longer just a crisis, that it is an emergency. It is no different than what we had in the pandemic. It is impacting just as many people, and it has it's as fatal as the pandemic was in many ways. And we did see that the impact of public-private partnerships, we did see that if we do want to accelerate in the case of pandemic, we can. Everyone came together, they worked together, the policy aspect, the reimbursement aspects, the science aspect, and to create vaccines that ultimately contain the pandemic in 2 years. I think that's what we need in mental health in general, and especially in maternal mental health. We need to see that kind of partnership, that kind of focus, that kind of accelerated path to meet that 90-90 moonshot goal, 90-90-90 moonshot goal. before 2033, frankly. But I think it's possible. I think it is possible because we've seen it happen before.
Fantastic. Nancy, your final thoughts?
Yes, so I'd say there's three things that are really important. One is that we need to be upstream and focusing on families and focusing on, the only way to evolve what I agree is a mental health emergency, it's been a crisis for a long time, is to build resilience among our families, right? Build buffering and build relational health, and so that families, we can break these transgenerational cycles of trauma and of mental health challenges. So I think that's one thing. We have to focus upstream, and perinatal health is the place to focus, because that's how we're going to impact generations to come. The second piece is, we have evidence-based intervention that work. We need to access them. So I recently read Tom Ellensell's book, and he talks about acute lymphoblastic leukemia. That's a childhood cancer that in the 70s was killing 90% of the population, of kids who got it. Only had a 10% survival rate. They have chemotherapies that worked. They were being implemented in a way that wasn't effective. They brought together people. They had a network of child cancer centers across the United States. The remission rate for ALL is now 90%. Only 10% of kids die. We have a similar challenge with perinatal mental health, and I'd say even more broadly, all women's health, in that we have evidence-based treatments that work. People are dying. We're not implementing them in a way that's effective. And when we can bring people together, all of these different partnerships, that can make a difference, and I am hopeful about that. The third thing is centering our communities, amplifying I love Ayanna Presley's quote, the people closest to the pain should be closest to the power. Amplifying and working within our communities, and we can all do that, whether it's telling our stories, whether it's doing our research, developing an app, doing data platforms. We all can play a piece in that. This is a movement that's very, very powerful, and we've been able to make change, particularly Jamie and her organization, despite changing administrations, changing many things. This movement can't be stopped. It's very powerful. It's coming from the light within everybody's wounds. And it is, I do feel very hopeful about that.
Great, and the final word?
Thank you.
Over to you.
We have a maternal health blueprint that came out of the White House. We have a maternal health blueprint that came out of the National Governors Association. We have a maternal blueprint that came out of the Commonwealth of Massachusetts. This issue is not going away any time and any soon. We just saw Kentucky pass comprehensive maternal health policy. We know that what maternal mental health challenges are. We know it's the leading cause of maternal mortality. We know what the spectrum of disorders are. We also know this is the only temporary and treatable mental health challenge out there. And that is something that's very unique in the mental health space. We know that we have evidence-based care, and we have evidence-based models that are being developed technology-wise off of that, and that's where this team comes in. And our end result is healthy families. That's as American pie and as baseball as it gets. And if you give communities and families what they need, that means people are going to be healthy. That reduces overall costs in all of the community needs. And that dollar discussion right there should be enough to move people towards healthier policies.
All right, on that, please join me in thanking these wonderful women and panelists.